So our next session is the next generation IOL power calculation and toric calculations. So many things are advancing in the IOL power calculation system. So many instruments are coming up, optical biometrics are coming up, so many new formulas are coming up. So it is always confusing for everybody that what is going on the IOL power calculation. So this is an advanced course where we all are going to introduce all these. We are going to talk about which are the newer formulas are going to be used in which conditions, and specifically in abnormal conditions where the post-vitreous eyes or a patient has already undergone the LASIK surgery, or a patient who have a pediatric eyes, how to go for the IOL power calculations for that. Our first speaker is Dr. Arshul Tak, but he is busy with some other session, so we start with the second talk.
So, we will invite our chief instructor of the course, Dr. Twinkle Shah, and he is going to talk to us about new generation IOL power calculation formulae and overview. Dr. Twinkle.
I'm very much thankful to the scientific committee chairman, Dr. Partho Vishwas, and the organizers to giving me this opportunity. My today's focus is on the next generation IOL power calculation. In era of 2020, we were going for the excellent effective outcome. But now in 2023, the expectation is the beyond excellent effective outcome. So the progress in the IOL power calculation is the advancement in the imaging devices, which will be taken care by the Dr. Arshul Tak for the optical biometries and the newer IOL power calculation formulas, software for the data integration, and the post-operative reflection adjustments. But today's focus will be on the newer IOL power calculation formulas. In 2017, Dr. Kwok has introduced a new classification rather than going the first generation, second generation or third generation. He has simply divided according to the way of the working of the formulas, like a historical or regression based formulas or regression formulas. The version formulas, Gaussian optics, where we all are using since so many years, like all are working on the basic principle of the cornea as a single plane, lens as a single plane, and you calculate the effective lens position by using the different variables. So variable like a third generation formula where axial length and the keratometry and the Higgins formula and the Ladas formula using the antechamber depth, or Barrett universal 2 was considering the two more modality of the variables like lens thickness and the white to white, and Holiday 2 was considering the edge factor and the preoperative refraction factors. Then the artificial intelligence comes place. The Hill RBF is also giving exclusively based on the artificial intelligence, but so many other formulas are coming up which are incorporating the theoretical model along with the artificial intelligence formulas. And of course, the way the ray tracing formulas are also coming up, that is the different optics, the pure optics phenomena, where the oculics or phaco optics or Olsen formulas are also has been classified. So the newer updates of the newer equipments like optical biometers are now have very much minimal error with the IOL power calculation is the contribution, and then more and more advanced is the like Argos optical biometer, where there has a segmented optical biometry has been also measured. The same way the keratometry has been also very well measured by the front surface of the cornea or the back surface of the cornea, and you can calculate by the vector addition by the Simplex images or the OCT or color-based LEDs. So the source of error in the magnitude of IOL power calculation is the effective lens position, not the keratometry measurement or axial length measurements. So why the majority of formulas are imperfect for the ELP issues are there? When the normal eyes are there, all the formulas are working very well. But when there is abnormal eyes, short eyes or very long eyes, or have abnormal eyes like antechamber, enamel is like small antechamber with the normal eyes or large antechamber with the normal eyes. In such conditions, this ELP issue is coming up. So the newer formula has to be evolved. So as and when newer formulas are evolving, we are taking the more and more predictors or variables taken in account. Now majority of the formulas are considering the lens thickness part or some are also considering the white to white thickness, or some are considering the like panacea, the corneal asphericity part or posterior anterior ratio of the cornea has also been considered by the different formulas. So which formula to be used in 2023? The left side is all the formulas we were using. Now the EVO, HEAL, RBF, Offer 5, Panacea, Pearl DGS, VRF, so many formulas are coming up. So it is now confusing what to use and when to use. So which formula in 2023? The top formula commonly used are the Barrett Universal 2, CAN formula, HEAL RBF, calculator version 3, Olson, Offer QST has been recently introduced for the long eyes, EVO formula, Pearl DGS, Barrett 2 axis length formulas, Betal formula. This is exclusively made for the design for the sum of segment biometries. So we go briefly one by one to all of them. The Barrett suite, which is available in so many equipments like IOL Master 700, they have three components. One is the non-toric component where the Barrett Universal 2 formula can be used. Toric IOL, Barrett toric calculator is also incorporated, and patient of the post-refractive surgery where the Barrett 2K formula has been used. Two more formulas are also available on the APS website of the Barrett. That is a Barrett treatment formula for the post-operative refractive surprise management, and Barrett 2K toric calculator where the post-refractive surgery toric IOL calculations. And the Barrett formula is mainly theoretical model with using the 5 variables, which is a thick lens based formula. So they have two factors. One is the lens factor, which is like our A constant of the SRKT, and the design factor, like I suppose a biconvex lens, the design factor will be changed, and the meniscus lens, like high myopic lenses, then the design factor will be changed. And the Barrett toric calculator also taking the care of the posterior corneal power, whether it is estimated or measure can be used. HEAL RBF calculator, that is a version 3 calculator. They are artificial intelligence machine learning process, that is adaptive learning. And it is initially when HEAL RBF has introduced the version 1, it was considering as a target hemetropia with only 3 variables. Now they are incorporated the 8 variables. They are also incorporate the data set of the small short eyes or very short eyes or small long eyes and very long eyes. And also rather than target hemetropia, you can also customize point plus or minus 0.25 and plus 0.5. Ray tracing formulas are also purely on the pure optics, very useful for the complex cornea, particularly when the corneal scar is there for post-refractive surgeries. In such corneas, they works very well. Where the keratometry readings are not properly, the ray tracing formula works very well. Olson is one of the ray tracing formula where another factor, C constant, is already there. That means there is a position of the IOL in the fraction of the capsular bag. So that C constant has been taken along with the Olson formula. Newer formula like a EVO formula, that is based on the theory of hemetropia factor or hemetopization, which is generating the hemetropia factor. It is also thick lens based formula, so it works very well when there is a meniscus lens are used. CAN formula, it is also nearly equivalent to the Barrett tube formula, but it has also incorporated the regression factor and the artificial intelligence component. They are maintaining the accuracy and the extreme of the excellence. Pearl DGS calculator, this is another good calculator. These three gentlemen has introduced this calculator, and it works based on the artificial intelligence and pure optics. And they have another additional advantage that they can adjust the prediction of the post-operative data of the control little eye. So suppose you have a refractive error in the one eye, so you should use for the Pearl DGS calculator where you can go for the other eye correction. This is the most recently introduced is the ES series IOL calculator, which is available to all of us free online and which incorporates so many formulas, that is Barrett, Cook 6, EVO, HEAL RBF, Offer Q, CAN and Pearl DGS. Just we have to put the data and all 7 formulas are coming up as a result. So it works very well for us. The latest evidence is that the CAN is the most accurate. This study was conducted by the Millis, and the CAN was considered as one of the best formula for that. And Olson and Barrett also similarly well. So so many formulas are there. How to incorporate these formulas in the practice? I will just briefly go through it. Then you should have a strategy for that. Till now we were considering each and every formula to be calculated separately, and we are optimizing it. So like this patient, suppose patient is a myopia, and I have selected a 17 diopter lens. The spherical equivalence is plus 0.707. Now because we have a calculator, now we can calculate so many formulas at a time. So put this data, you will get the results. And suppose you go for the 16 diopter, calculate which is the range of the corrections in the different formulas. So plus 0.17 to plus 0.06. And this is 16.5, the range is minus 0.5 to 0.26. So being a considered patient as a myopic, I would like to keep a little bit more on the myopic side. So 16.5 diopter lens has to be selected. So now you can incorporate so many formulas at a time, which is real time available online on EA series calculator. Thanks for your attention.
Twinkle, hello. Good morning, and sorry for that. At the outset, I would like to thank the AIOC, the scientific committee, and Dr. Twinkle for giving me this opportunity. In fact, this course has been there for at least 4 years now, and we keep on talking about newer and newer things in IOL power calculations. So I'm going to talk about IOL power in abnormal situation, and I'm going to stick to long eyes and short eyes, or you can say very long eyes and very short eyes only. So let's start with the long eyes. When do we identify or call as an eye as a long eye? We mean that the axial length is more than 24.5 millimeters. Now, what are the issues with an eye which is more than 24.5 mm? Well, the two issues are there could be a measurement error and there could be a formula errors, because as the eyeball grows, we need to have a different and a very specific formula for that. So coming back to very high myopic patients, and how can we have a measurement error? Well, the axial length measurement is is where we will falter, and one of the problems is the fixation issue. The patient might not be fixating properly, but more importantly, anatomical one is the posterior staphyloma, and this is the reason that these eyes need an optical biometer, and we have tried and not do any immersion. Of course, you all know there is no contact biometry in these modern days. Well, we might go ahead, but at least immersion, but most probably in all these patients, an optical biometry. Why do we have measurement errors in high myopia? There is a vitreous liquefaction in eyes with axial myopia, and so the refractive index of vitreous may be different. For us till now, the refractive index was like one glove fits all, but no, now we have understood that different parts of the eye will have different refractive index. So the Gulstrand standard refractive index is no more accurate due to the longer optical path, and it also leads to an overestimate of the axial length, especially giving you an hyperopic surprise. So Wong-Koch formulas for adjusting in axial lengths in eyes more than 25.2 is actually a very good one, and it is a formula which a lot of people also use. Holliday, Haggis, Ersarkety and Hoffer-Q, these were the ones which were actually used. But the long eye Wong-Koch adjustment is something that we should all understand. It compensates the overestimation of the axial length. This Wong-Kok adjustment reduces the axial length by a formula-specific coefficient. This is all math. Holiday works better up to axial length of 26.5. SRKT works better for axial length more than 27 millimeters. These are all quite aggressive methods and they give surprises of myopic errors. So ULIB modified and re-optimized it, ULIB. So better to go to ULIB site to use this Wong-Kok adjustment. I'll explain to you in the next slide. And never use all these formulas in post-refractive surgery eyes. They are a different subset of eyes. So the Wong-Kok adjustment or the ULIB formula, it is used for axial length of more than 26.5. There is an Holiday 1 optimized axial length and there is an SRKT optimized axial length also, and these have been very well validated. Another tool in the market or the new toy in the market is the Argos swept source OCT biometer. What is so unique about is sum of all segments. As you can see, it believes that a segmented method should be there for each part of the axial length because there are different structures involved. There are different refractive indexes for each of them. And so the Argos measures an axial length specifically for each segment of the eye. And this is the formula for that. And the axial length is become the sum of all segments or SOS. So the spatial formulas for such kind of biometry are the Barat true axial length or the BTL, which is specially designed for SOS only. Other Pearl DGS and EVO formulas are also there for Argos SOS biometry. But if you say a specific one, it's the Barat true axial length formula, which is for SOS machines only. A nice study was done in 2018 by Mellis, and for long eyes, the top three options at that time in 2018 were Olsen, the Barrett, and the Haggis unadjusted formula. Ones to avoid, we have to be very sure, is to be Holiday 1 and the Hoffer Q. The things to note in this study were that Holiday 2 has been updated and improved. The Wong-Kok adjustment is now great, and the Hale RBF, Kane, and EVO were not included in this 2018 study. So subsequently, the formulas which are now used is, for example, in all long eyes, we would go ahead with Barrett, Kane, Hale RBF, and Olsen because they work very well in all the lengths of long eyes. If you want to use the third generation formulae, go to ULIB Wong-Kok modified Holiday 1 for up to axial length of 26.5 and ULIB Wong-Kok modified SRK-T for axial length of more than 27 mm. The newer modification of Holiday, the NLR for high myopia, also gives a good performance. So in summary, for long eyes, optical biometry of course overperforms the immersion biometry. This is the gold standard now. Newer SOS, sum of all segment biometry, is an emerging concept. The Kane Barrett Hill RBF version 3.0 works very well. And for third generation formula, use only ULIP modified Wong-Kok adjustment. Now coming to short eyes. Well, when do we quantify as a short eye? Less than 22 millimeters of axial length. And what are the parameters that are very important? One of them is the axial position of the IOL becomes very important in this type of eyes. Higher power IOL, small shift in position, big impact leads to that. And only a 1 millimeter shift of the effective lens position, the ELP, results in a 2.75 diopters at spectacle plane for a 34 diopter IOL. And mind you, I'm talking only about the short eyes where the IOL powers are more than 30 diopters. The shape factor in IOL design varies with power, and high degree of spherical aberration in higher power spherical IOLs also is an issue. For short eyes, the accurate measurement is a key again, and the two important parameters are the axial length. Error in axial length measurements have higher impact in short eyes. For example, error caused by 1 millimeter of corneal compression leads to, in an average, 2.5 diopters, but in a short eye it leads to a surprise of as high as 3.75 diopters. And that's the reason we have to be even more accurate in short eyes. Similarly, the effective lens position, the accurate prediction of post-operative AC depth is particularly important in short eyes because an error of only just 0.25 mm leads to 0.1 diopters in 30 millimeters of axial length, and in axial length of near about 20, it leads to a surprise of 0.6 diopters. So all these things, when they add up, they give you at the end of the procedure about 3, 4, 5 diopters of surprise, and that is what you would definitely not want. So for short eyes, which formula? Well, Hoffer Q, it is an outdated concept. It was when third generation versions formulas when you use. For some reason, it got stuck in everybody's head that you are supposed to use Hoffer Q. Holiday 1 may be better, and newer methods like Barrett and Hill RBF also do much better. Studies conducted in 2016 by Kane and 2018 by Mellis, and it actually showed that Hoffer Q is one of the poorest formula for short eyes. Barrett and Holiday 1 performed better in 21 and 22 millimeters of range. And this is the study of OLCR or the Lenstar machine versus the IOL master machine. And they found out that if you are going to use a Lenstar, for short eyes, use Olsen standalone or a Barrett or Olsen OLCR and the Haigis one in the Holiday formula. While for IOL master, you can use a Barrett or a T2 and the Haigis or Holiday 1 formula. So, Oculix and Olsen ray tracing show the smallest spread and smallest systematic offset. Barrett Universal 2 is widely regarded as the best conventional formula. It does not perform well in the series of eyes and is actually worse than older formula. Holiday 2 shows no improvement over Holiday 1. Hoffer Q no better than other formula. Hill RBF performs as good as Haigis but not better. More than 50% of data sets leads to error message of out of band whenever you are trying to use this formula. And entering lens thickness data, the CCT order and the white to white into the Hill RBF makes absolutely no difference in IOL power calculation. We were told a lot of things about all this. So what is coming up for short eyes? The lens thickness can improve IOL position prediction because as you saw ELP, the post-surgical ELP is of very importance. Newer SS OCT with lens tomography, modeling of crystalline lens is possible. Superimposing lens pre and post-op data will help in understanding of the problem. So what should we do for short eyes now? Well, ray tracing works better. Oculix and Phaco optics performs better. Barrett and Holiday should be avoided in short eyes, while the Haigis, Olsen and Hill RBF version results are very comparable. Very important in very high hypermetropia eyes that you might need to customize your IOL, or you might even need to do a piggyback IOL. We might go ahead and make a flap and try to do an adjustment, but as you all know, a bioptics with a hyperopic correction is always very difficult. So the first there is a formula for all these kind of patients where you want to do piggyback IOL. First IOL in the bag, second in the sulcus is the norm. You use Holiday IOL constant R formula. This works very well. Many times we might not have to do this. This is also done by the suppliers. And in the second in the bag, intralenticulaar membranes, IOL opacification, CDVA loss, all these things are a problem, but we need to just address that we might need to do a piggyback IOL in extreme hyperopia patients. So in summary, the newer IOL calculation preferences are for standard cases. This is one slide which sums up all. Standard cases for normal axial length, Barrett Universal 2, Hill RBF version 3.0, Olsen and Holiday 1, or even the SRKT are good. But for high myopes, which we qualify as 20.5 to 27, Holiday 1 with Wangkok modification or the ULIP modification, Barrett Universal 2, the Kane, the Olsen and the Hill RBF version 3.0 also work very well. For very long eyes, which is more than 27 millimeters, Barrett Universal 2 and Hill RBF version 3.0 and Kane work very well. And for short eyes, well again, not very, very accurate, but the ray tracing with ILT and the Olsen and Oculix formula are going to work well. Again, Hill RBF version 3.0, Hoffer Q and Haigis optimized and the Barrett Universal 2 can be used for the short eyes. Thank you very much.
Thank you, Dr. Tejas. Now I invite Dr. Harshul Tak for his talk about the newer generation optical biometers.
Thank you so much, Dr. Twinkle, for including me in your course. And we have been doing this course for many years now. And a warm good morning to all the delegates who are here in this early session. So I'll be speaking on advances in optical biometry. We all know that biometry is a practice of applying mathematics to biology. So broadly, biometry systems, we all know, are ultrasound based or optical biometry based. So A-scan ultrasound, it uses sound wave frequency of 10 megahertz and it has accuracy of 0.1 millimeters. The high frequency probe used in A-scan, it has minimal depth of penetration and which is excellent for resolution of smaller structure. That is, we use it for eye. But there are limitations of ultrasound A-scan. We all know that ultrasound, it depends on, it doesn't depend on patient fixation. It just measures the optical anatomical axial length of the eye from anterior to the posterior pole and not along the visual axis of the eye. So this is one limitation of A-scan. The second problem with ultrasound biometry is that it measures in front of the retina, that is from the internal limiting membrane. Whereas if you look at the optical biometry, these two problems are solved. That firstly, optical biometer, they measure the true optical axial length along visual axis of the eye. And secondly, it measures from the photoreceptors on the back of the retina where we get the true axial length of the eye. So if we have a look at the system on which the optical biometer work, basically they all are based on laser interferometry. So where there is one source of light which is split by a beam splitter, and there is a detector which measures the difference in the distances or path which the lights have traveled. So this is the Michelson interferometer on which all the biometers are based. So different OCTs, we have seen that we have evolved from the time domain OCT in which the constant phase difference waves were used to the spectral domain and the swept source based OCTs now which are used. So basically the basic difference in the spectral domain and swept source OCT is how the light is basically captured. So in spectral domain OCT, if you see, there is a photodetector at which the interference is done. Whereas in the swept source OCT, the light source which is used, which itself is a sweeping source, it has a variable wavelength. So that's the basic difference. So the first optical biometer which came in market was IOL Master 500, and the IOL Master 500 was based on the principle of partial coherence interferometry. It used a 780 nanometer multimodal luminescent diode. But the limitation here was that this IOL Master 500 only measured axial length truly optically. All other parameters which we need for the newer generation formulas like the antechamber depth, lens thickness, ACD, they're not measured by IOL Master 500. Then came Lenstar 900, which was based on optical low coherence reflectometry, and it used 820 nanometer superluminescent diode. So it truly measured corneal thickness, ACD, lens thickness, and axial length. So this is the basic two difference in the IOL Master 500, which use PCI, and the OLCR by Lenstar. So basically the light source used in the IOL Master 500 is the MMLD. As you can see, it's a multimodal luminescent diode. So it creates a lot of secondary maximal waves. That's why it cannot measure through ACD, lens thickness and corneal thickness. Whereas in OLCR, it uses SLD, so it gives a continuous wave. And secondly, the setup which is used of the both the systems is different. PCI use dual beam setup, whereas OLCR uses a rotating glass cube system. So then came ALScan, which was again based on partial coherence interferometry. It used So 830 nanometer SLD to measure axial length. Then came Aladdin, which is based on OLCI, that is optical low coherence interferometry. So limitations still IOL Master 500 and OLCR, Lenstar and all these instruments were not in measuring axial length, but was in the penetration in the denser cataracts, because they were not able to penetrate through the dense subcapsular cataract and denser cataract, and they only measured anterior cornea. So then came the instruments which are now based on the swept source OCT. The advantage, as I said, is they can penetrate better through the denser cataracts, and they also measure the posterior cornea, so that gives total keratometry, as Dr. Twinkle also mentioned. So IOL Master 700 is based on swept source OCT, and it has a scanning rate of 2000 scan per second, and it gives corneal thickness, antichamber depth, lens thickness, axial length values. So it measures keratometry in 3 zones, 1.5, 2.5 and 3.2 millimeters, as you can see here. So these are the 2000 scans which are taken per second in 6 quadrant, 0, 30, 60, 90, 120 and 150 degree. And you can actually see whether the fixation is proper or not, patient fixation. As you can see on the left side, we see a good foveal pit. It means it's a good fixation. So, as Dr. Tinkle also mentioned, it uses 3-zone keratometry, and 6 spots are used at 1.5, 2.5 and 3.5 millimeters. And it has incorporated Barrett TK formulas, like Barrett TK Universal 2 for normalized, Barrett TK toric, and Barrett True K with TK for post-refractive surgery eyes. It also gives angle kappa, which is the distance between visual axis and pupillary axis. Then another biometer which is there in market is OA2000 from Tomy. It's also based on swept source OCT. I'm personally using this for last 8 years. It has a scanning rate of 1250 scan per second and uses wavelength of 1060 to measure. It gives all the readings, axial length, ACD, CCT and lens thickness. It also has a Placido disc which has each ring has a 256 points which are projected on the central 5.5 millimeter of the cornea, and we can obtain K values at different diameters, 2, 2.5 and 3 millimeter. Then we have Argos, which is again based on swept source OCT. Then Anterion we have recently from Heidelberg, which uses wavelength of 1300 nanometers. So to conclude, swept source based OCDs, they provide repeatable and reproducible measurement in different ocular parameters, and they are more effective at obtaining measurements in eyes with denser cataracts. And they also provide good accuracy in IOL power calculation. And I think now optical biometry is the gold standard for doing all our IOL calculations. Thank you very much for giving this opportunity.
Thank you, Dr. Herschel, for giving in depth all the understanding about the optical biometer. Now I would like to invite Dr. Sonu Goyal for IOL power calculations in post-refractive eyes and keratoconus.
Very good morning to each one of us, and I'm extremely thankful, Dr. Twinkle Shah, for making me part of this course. And I think it's one of the few courses who have been repeated year after year. And thanks to the wonderful content that and the speakers Dr. Twinkle Shah has incorporated. So a quick question to all of you, the audience. So how many of you are into refractive practice? Any of you practice refractive? Yes. I see very few hands. And how many of you have those newer gadgets that Herschel had said, the optical biometers, access to optical biometers? Yeah, so I think yes, few of them. So what is more important is that when you get these extreme of the patients, long, short, post-refractive, I think these are real challenges. And even if you don't have an access, the best thing could be you can calibrate your own devices to suit those needs. And these are those tricky patients who would always give you refractive surprises. So the whole purpose of the course is to, embrace these extreme situations. So what I'll be talking is, the next 10 minutes is patients where you have post-LASIK, post-SMILE, post-RK, and post-keratoconus, and keratoconus patients, maybe they are cross-linked. So these are those bundle of patients where you actually need to evaluate and move forward for the calculations. We all know that now we have a high volume of refractive surgeries which are being performed worldwide. So we have a huge volume of these patients who have been coming to us. And moreover, refractive surprises lead to dissatisfaction, because these are those patients who got refractive surgery to have that 20/20 vision day one. And these patients, when taken after cataract, would always require or always expect the same quality of vision post-cataract surgery. So an accurate biometry is essential to attain the best or the visual outcomes in these subset of population. The major concerns in post-refractive eyes is basically the expectation, as I already told. There is a difficulty in the IOL calculation because of the multimodal problems. There are incision issues when you're dealing with post-RK eyes, because we have 4 cuts, 16 cuts, 18, 24 cuts, and extending near to the limbus. So these are those patients where we have to be extra careful, because otherwise the incisions start ripping off. There is issue of visual quality. Then there are difficulty in the IOL selection, because most of these patients would always need a kind of a presbyopic IOL correction, which is difficult in these subset of population. And definitely these are those patients who have been suffering from dry eye issues, maybe because of their post-refractive surgeries. So the IOL calculation requirements, as we all know, basically includes the excellent calculation. Now the central K, where I mean the anterior and the posterior K in all these patients. Now we have to take care of the surgically induced astigmatism, which we will be inducing. So there could be some amount of corneal or lenticular astigmatism in these patients, and ELP, or the effective lens position, is one very important key factor, which is the whole source of misery in these subset of population. Now, talking what are the errors actually we are talking about in these subset of population. So error number 1 is in the prior myopic LASIK patients is the radius error. So what I actually mean by radius errors is that when you do a refractive surgery, you calculate out what is the optical zone required. Sometimes you can end up with decentration and little islands where you have actually not ablated, or you have decentered the ablation, and there could be some central islands left, and whether you have done a wavefront optimized or customized treatment. So that all translates onto the cornea, and this is what ultimately leads to those refractive surprises. So how do you do it? Post-LASIK, the wide range of curvature within the central 3 mm zone is what is the concern. So you can have a larger optic zone. Sometimes patients have been treated with very, very small optic zone because of if you're treating high refractive errors, wavefront or standard ablations, decentration, as I said. So, and in keratoconus, you can miss the central flatter areas. The concern number 2, or the error in IOL power calculation number 2, is actually the keratometer that you're using basically works on the principle of a fixed ratio. So basically you have 1.3375, which is the ratio between the anterior and the posterior, and that's why you calculate out the curvature. But in myopia, what is actually happening is you're flattening the anterior corneal surface. And this is what alters the relationship between the anterior and the posterior corneal surface. So keratometers and topographers usually overestimate the corneal power, and it is basically around 1 diopter for every 7 diopters of refractive correction, and that is what translates into your hyperopic shift. So most of these patients, if you're just taking consideration of the anterior curvature, you will end up landing up in hyperopic shifts. So you have to have what Dr. Harshul pointed out, the newer devices which actually give you both the anterior and the posterior. So this could be Pentacam, which gives you a total or the true K or the net K, and then you can have Galilei, or you can have IOL Master 700, which gives you the true K or the net K in most of these patients, which takes assumptions of both the posterior and the anterior. So the conventional keratometers, basically the corneal power calculated is at 3 millimeters. So average is between 2.8 to 3.7 millimeter zone. And it works on this assumption of the fixed anterior and the posterior corneal curvature, which we call as the Gould-Strand ratio. Now that is the alteration has been done once you have performed RK or myopic LASIK ablation in these patients. So the error number third in these is the error pertaining to the formula itself. Now what happens is when you are treating these third generation formulas like Hoffa-Q, Holiday, SRKT, they work on basically calculating out the keratometric readings and the axial length, and that is what, based on that, they assume an anterior chamber depth and effective lens position. Now since there is an alteration in the anterior curvature, and that misleads to giving a effective lens position which is abnormal. So following LASIK, you can have low estimating. It is estimated that the IOL will sit more anteriorly, and this results in the calculation of a low power IOL. That means a hyperopic surprise. So at the end of the day, 1 millimeter error in the ELP corresponds to almost 1.5 diopter change in the final refraction. So in these eyes where you have done the myopic ablation, if the flattened post-operative corneal power is used to calculate out the ELP, the predicted ELP will be falsely shallow and result in the underestimation of the IOL power, and hence you get a refractive surprise. So this is one of the articles where they predicted the refractive prediction errors with the three formulas. If you see the Sharma's, Higgins L, and the Barrett K. So there is prediction errors, and there is a significant difference in the refractive prediction errors. And what is the solution to this now? So you need to actually measure or estimate the true corneal power, which we call it the net K or the true K, by applying objectively or by applying certain correction factors by the keratometry. And you have to use formulas which are not solely based on keratometry and axial length, and there are correction factors for accurate estimation of the effective lens position. So you can either have objectively means the total keratometry, the TK, which is available on the IOL Master 700. You can have applying correction factors for keratometry like the Pentacam EKR, and selecting, this is very important, the 4.5 millimeter zone, because that is what the pupil size for the normal Indian eyes is. And then you can have formulas which are not solely relying on the keratometry and axial length, and they add in correction factors for the accurate estimation of the ELP. So this could be the Holiday 2 and the Barrett's True K Universal 2. So these are the two formulas which actually take care of the ELP. So the conventional approach, you can have the pre-operative refractive data. If your patient has pre-LASIK or pre-RK refractive errors, the data, and you can use put these on the online calculators. You can go to the ASCRS or the ESRS website, and you can compare the various methods. So this is basically history versus no history methods. So a quick word of TK, though Harshul has covered this. So it's a very nice method of, telecentric keratometry and the swept source OCT. It measures actually the posterior corneal curvature, and it's incorporated in the IOL Master 700 with the latest software. And these two formulas, the Barrett TK Universal 2 and the Barrett TK Toric, have incorporated. So this is a quick description of what this 700 is. So it takes care of the posterior and the anterior, and it gives you, there is no reliance on the pre-operative history. You actually don't need it, and you can objectively measure the actual values, and the newer generation IOL formulas work very nicely under this. So this is one beautiful article where, the intraocular lens calculation after refractive surgery. This was a long-term retrospective comparison of the 8 formulas. So if you happen to see here, again, the Barrett True K and the Barrett True K Net K works very well. And in all of these long-term, close to 3 months, if you see, almost bang on target. So one beautiful article which I just went through was this work done by Dr. Sri Ganesh on this, where he compared the performance in post-refractive surgeries, TK with Barrett's Universal 2, Pentacam EKR plus Holiday 2, Barrett's True K post-refractive surgery formulas. Now all of these formulas performed very well, and their estimation was almost less than 0.75. So total keratometry with Barrett TK 2 provided comparatively predictable outcomes. So bang on target with all these formulas. A quick word of post-RK. RK actually changes both the anterior and the posterior K readings. So normally, the corneal thickness remaining the same, but normally posterior to anterior is like -6, but RK actually changes both the anterior and the posterior. So you actually need to go and see the central flattened, the most flattened area in these RK patients. And what is more important is the scleral versus the corneal incisions, if you're taking into consideration. There could be some amount of diurnal variations in these patients, and there is usually hyperopic progression. So intentionally, you target a little myopia in these RK patients. A quick word with keratoconus, though it's again a different set of ball game. In keratoconus, there are a lot of errors where you can end up. So keratometry itself is difficult in these patients because actually the central K and K at different levels could be giving you a lot of variations, and which actually leads to sometimes overestimation, underestimation. So you can have hyperopic as well as myopic surprises with these keratogenic patients. So literature, SRKT or the Barrett Universal 2, and these two formulas, they are the still work good with keratoconus patients. So you have specifically designed IOL formulas for keratoconus, which really work well. And I think Barrett True K keratoconus is one which, though if you see in the next slide, they would not be really 100%, but yes, close to maybe 80 to 90%, that works well. So in these keratoconus patients, so estimating the corneal curvature, estimating the axial length is again a big issue in these keratoconus patients. So True KTK, post-myopic LASIK, and it was a multi-center study again done by Graham Barrett. So where they compared retrospective analysis of no history, and they found out the errors in predicted refraction, and they compared the True KTK versus True K on Hagees L, Hagees TK, and Sharma's. So they came out that the spherical power prediction with True K TK, if you see, the mean error was the minimum with this. So True K TK, I think, works very well. So to conclude, you can use the ASCRS online calculator, try to obtain pre-LASIK if you have the data. Barrett True K, I think, works very well. And Aura, in case if you are have an access intraoperatively, you can still, in the best of the hands is not available. And you can always, and you should always, discuss the difficulty and the chances of surprise with the patient, so that the patient doesn't come up the next day with some, filthy allegations. And always under promise, then over deliver. Thank you very much.
Thank you, Dr. Sunu, for giving me very good insight about how to deal with the post-refractory surgery patients. Now I'd like to invite Dr. Soumil Kothari and how to calculate IOL power calculation in post-vitreotomized eyes, particularly when the patient has undergone the RD surgeries, or patient who are undergone RD surgeries, they are all, majority of them have high myopia. So sometimes it's a tricky situation, or sometimes the eye is filled with the silicone oil. So that is also sometimes a tricky situations. So there's something hearing about what is happening on that field. Dr. Soumil.
Thank you, Dr. Twinkle. I thank Dr. Twinkle and the organizers for AIOC, and it's lovely to see all of you in Cochin. So I'll be speaking on IOL power calculations in post-vitrectomized eyes. Now, cataract surgery as of today, the expectations of our patients are very high, and everyone wants a perfect outcome after cataract surgery, irrespective of whatever preconditions that the eyes may have. But the definite reality is that we cannot so many times deliver up to these expectations of our patients. So there's a mismatch between expectations and reality. So how do we achieve our target refraction in such post-vitrectomized eyes? So what are the considerations post-vitrectomy? There are three main considerations. One is measuring the correct axial length in silicon oil filled eyes. Second is getting the correct IOL power. And the third is choosing the appropriate IOL material. So talking about the first thing, measuring the correct axial length. Now why is it a problem in silicon oil filled eyes? Because silicon oil reduces the speed of sound traveling through the eye in our traditional biometers. So if we use 1000 centi-Stokes silicon oil, it is a speed of, the velocity of sound is 980 meters per second. If we use a denser silicon oil, then the velocity increases to 1040, and in the normal vitreous cavity, otherwise it is of 1532 meters per second. That is one. The second issue is the higher refractive index of silicon oil leads to a hypermetropic shift of refractive error by approximately anything between 4 to 8 diopters. Also, we have poor quality of echoes, and there is reduplication of echoes because of the silicon oil itself. So getting the correct measurement of the axial length is an issue. So what's the solution? Now, in basic biometers, we can use a correction factor of 0.71, which is averaged out for the 1300 centi-Stokes silicon oil used to measure the axial length. So for example, if the axial length measured in the standard mode is 37.50, because it is always going to be longer, the measured axial length is going to be longer because the perceived speed of sound is slower. So the actual axial length will be 37.5 multiplied by 0.71, which amounts to 26.63. So this is just one fudge factor which can be used. In most of our biometers, which are better biometers, which they have a silicon oil filled mode in our biometers, which are incorporated. So you can just change it to the silicon oil filled eye mode and measure accordingly. So it will already do this calculation inbuilt. But of course it is best to use the newer optical biometers because they give an actual axial length in such situations. Now what if you don't get a good scan? First, preemptive, before you actually go in for the surgery, measure the axial length prior to VR surgery for use at a later date. So you're planning a vitrectomy surgery and then later on you're planning a cataract as well. Even though they have not developed a cataract now, you should measure the axial length. And or you can perform an SOR and then re-measure axial length. The other alternative is use an intraoperative aberrometry or retinoscopy after removal of the cataract. And the fourth one, which is the least preferred option, is use the axial length of the contralateral eye. So this is about measuring the axial length. Now what about IOL power calculation? Which formula do we choose? Previous speakers have elucidated various formulae. The broad division of formulae can be divided into older and newer. The older ones based on regression and basic theoretical optics. The newer ones are based on more advanced theoretical optics. The previous one, they have only 2-3 variables. Of course, the newer ones have more variables. And the older ones are less accurate, and these are more accurate in terms of in general. So this is an article which compared all the formulae and compared 8 formulae, not all, but the Kane, Barrett, 2, Pearl, Evo, Huygens, all were all compared, and they all found out that more or less they did rate Kane to be higher than Barrett Universal 2, but if you see the mean error is minus 0.14 or to minus 1.5. So it's not really ranging much. There's not much of a clinical range between all these formula. You can choose more or less any formula which you are preferred to for your regular cataract surgery. My preference is the Barrett Universal 2. That is my go-to formula for most situations. So that is about the IOL formula. And of course, as far as the IOL material is concerned, we have to choose an appropriate IOL material, that is to avoid silicon IOLs and silicon oil filled eyes. And it's best to use either the acrylic or the PMMA IOLs. So just to summarize my talk, use newer biometers to measure the axial length accurately. use newer formulae like the cane or the Barrett for IOL power calculations, and avoid using silicone oil in these situations, silicone IOLs in these situations. So as Shakespeare would say, oil is when that ends well. Thank you very much.
Thank you, Dr. Soumil. One question. We had already undergone the Dr. Sonu's talk about the how to deal with the post refractive surgery, and your talk is about the post-picturized eyes. Suppose a patient has undergone the patient wants to go for the cataract surgery, who has undergone the refractive surgery like RK surgery, and now patient is already have a silicone filled eye. Which formula would you like to use for that?
So incidentally, I had this very high profile patient, an actress and a singer, who was a high myope, underwent refractive surgery LASIK, then had an RD, underwent RD surgery, and now had a cataract, and I had to deal with that. So it's very tough in these situations any which ways. So you know about it, you have to counsel the patient regarding all the possible consequences. You have to make them understand that this is not a normal situation. This is a tough situation as far as getting emetropia is concerned. We will try our best, but it may have some variations. So we have to be prepared. That is, lower their expectations in the first go itself. And secondly, again, if we break it step by step, and if we consider the Barrett or the newer formula, any of the newer formulae will do more or less quite well in any of these situations, as opposed to just the traditional SRK formulae. This is what my reading is. I would like the other panelists also to have their experiences or comments on this issue. And incidentally, for this one patient, it so happened that we achieved the target refraction.
Thank you, Dr. Soumil.
So, can I just...
Yeah, Dr. Soumil.
I'll just like to take a quick question. So you have a silicone-filled eye, you don't want to remove the silicone oil, and you just want to do away with the cataract. So, so in that case, your target would be an emetropia, or you will target, if you want, maybe after 3 months you remove the silicone oil, and then, you would target something add-on so that, once you remove the silicone oil, then the patient becomes emetropia. A lot of times we have patients being referred to us, silicone-filled eyes, mature cataract. What is the take on this?
So the thing is, the silicone oil is not going to be left permanently. That's the whole idea. So we have to consider that the silicone oil will be removed at some point of time and make our calculations accordingly. Either you do a combined cataract plus silicone oil removal, or even if you are doing a silicone oil removal, either if it's possible, do a SOR first and then measure it, or if it's not possible, do either combined. But if you have to leave the silicone oil behind and do it at a later date, make that into consideration, because the silicone oil will make a hyperopic shift of 4 to 8 diopters. Put that into your consideration as far as your target is. Don't target emetropia.
So that means that patient should be given a refractive error initially till the time we don't remove the silicone oil.
That's right.
That is the approach.
That's correct.
Okay, thank you.
Thank you, Dr. Soumil. Now I would like to invite Dr. Sahil Vasavada, because what we are talking about the normal adult eyes. Now, which IOL has to be implanted for the pediatric age group, particularly from the infantile age group to the years of 12 years, 13 years of eyes. So, Dr. Sahil has a wide experience about the IOL power implantation in the pediatric population. So, let's hear from him. Dr. Sahil, please.
Thank you very much, Dr. Twinkle sir, for this wonderful course. At the outset, I would like to acknowledge the contribution of my colleague, Dr. Deepa Agrawal, in making this presentation. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. I think accurate determination of the IOL power is one of the most major challenging parts in children undergoing cataract surgery. Unlike in adults, where all of your pre-operative planning usually ends up being right in 8 or 9 out of 10 eyes, in children it behaves very, very differently. It's just not a small adult eye. It's an extremely different ball game altogether. So for IOL power calculations, we need the biometric the IOL power, which formulas to use for such eyes, and the target refraction, which is of extreme importance in these eyes. The major difficulty is that unlike in adults, although you may have access to all the best equipments in the world, children in most situations are not going to be cooperating enough for you to take measurements on those wonderful instruments. So whenever possible in older children, cooperative children, which generally doesn't occur before 3, 4 or 5 years of age, try to get optical biometry and readings with the machines like you would do for older adults. However, for children typically less than 3, 4, 5 years of age, or sometimes even older children who are very uncooperative, it would be very difficult to do any form of examination in the outpatient clinic. And therefore for them, examination under anesthesia is the mainstay, not just for IOL power calculation, but for a complete thorough examination of the eye. Quite often we think it is cataract, but it turns out to be fetal vasculature with remnants that have been left behind, and so on and so forth. So you need to do a detailed eye examination along with IOL power calculation. Generally the handheld autokeratometers work reasonably well under anesthesia in such eyes. And the keratometry, there are several articles to suggest, average keratometry at different ages as well. So if you otherwise struggle or find it difficult to measure, you can use these formulas, these tables as well. Wherever possible, immersion biometry is definitely the way to go in measuring the axial length compared to contact. It will be difficult to do immersion biometry in very, very small children, and therefore, like in our case, we've got a customized Prager shell made of a very small size, because even that normal Prager shell may be difficult to fit in very young children or children less than 3, 4 years of age. And like in adults, there are also articles done amongst children to show that measuring with the contact method does have significant limitations in measuring the axial length. And like I said, alignment is also an issue. Coming to the IOL calculation formulas, unlike like we saw in the adults, where you have now 2 or 3 good formulas which seem to work across all different ranges like the Barrett's, Kane, Hale, RBF, Olson, in children it is very different. And if you actually undergo or go through the review of literature, there are several articles, and each of the articles seems to recommend a different formula. And that is because the eyes of children behave very differently. The eye itself behaves very differently if you operate at 3 months versus you operate at 3 years versus you operate at 10 years. So therefore there is no still one good consensus which can tell us that this is the formula to go to. We did our own studies, our own data analysis of our own pediatric cohort, and in our case we found the SRKT and the Holiday 2 to be the most accurate, and personalizing a constant like in adults didn't seem to help very much in children. We are still struggling. We are trying to get our data sorted out with the Barrett's formula as well, but there are several challenges that we are still facing. So maybe in the coming times this may change. But as of now, these are our 2 formula of choice as far as pediatric eyes goes. Coming to the important question of how much do you target refraction? Do you actually undercorrect, keeping in mind the growth of the eyeball that is going to occur? If yes, then by how much? Or do you go for target emetropia? So there are 2 schools of thought. One is if you go for closer to emetropia, which is not much of undercorrection, you are less likely to have too much of amblyopia in the beginning, but the chances of ending up with myopias of 10, 12, 13, 14 as they grow up are very, very high. And therefore the principle of leaving behind some amount of residual hypermetropia or undercorrection at the time of primary surgery, which has a slightly higher chance of amblyopia immediately, but lesser chances of extreme myopias occurring in the future. And that is one theory that is followed most commonly, because myopic shifts will occur no matter however good the surgery may be. Also, the age of surgery is also a very important determining factor for the rate of axial growth, because the maximum growth occurs in the first from birth until 18 months of age. So the maximum axial length grows between 0 to 6 months of age, then 6 to 18, and then 18 months onwards the axial growth really slows down. So it will also depend on if you are operating less than 6-month-old child or a child at more than 5, 6, 7 years of age. There are, once again, like keratometry, there are normative databases to suggest in a normal eye what would be the growing pattern, but however these are meant for normal eyes, and a cataract eye may behave quite differently than a normal child growing eye. The rate of axial length we found in our study was higher in children less than 1 year of age, and it was higher in pseudophakic eyes compared to aphakic eyes, and more so in unilateral pseudophakia, which means if a child has a unilateral cataract, that eye is likely to grow much, much faster and much longer compared to a normal eye, the fellow eye, which doesn't have cataract. So the key consensus that all pediatric surgeons follow is to undercorrect the eye depending on the age and the laterality. So it depends on the age of the child, the axial length. Say for example, if the child is already myope as of now, keeping in mind his age and what the normal axial length would be, you think differently. And if it's a unilateral cataract, like I said, you need to keep in mind two factors. One is amblyopia and also anisometropia with the other eyes. Once again, there are several articles to suggest a blanket sort of undercorrection, like this suggested by Plager and group, that as per the age, you undercorrect by +5, +4, +3, so on and so forth. Dr. Trivedi and Dr. Wilson and their group have once again also suggested, based on age, that younger the child, more the undercorrection. With our data analysis, this is the pattern that we follow, that in a very young child, less than 3 months, we undercorrect by about 35%. And as the child keeps growing older, we undercorrect lesser and lesser, to the fact that anything beyond 6 to 7 years of age, we hardly undercorrect. That is, we undercorrect only by about 2 to 5%. But younger the child, more the undercorrection. That is the consensus across all of these articles. So I'll just share 2-3 case scenarios to highlight that. This was a 4-month and 20-day-old child, bilateral congenital cataract, having normal, similar axial length in both eyes and normal for their age. So keeping this in mind, that he falls into this category of 3 to 6 months, we are looking at an undercorrection of about 30% from his actual power. So when we calculate with using the SRKT, the emetropic power turns out to be 36, and doing a 30% reduction in this, that would be deducting 10 diopters. So 26 is the rough power that we would choose for this eye, which this child underwent, and these are his subsequent sequential refractions post-operatively, starting from 1 month until 5 years post-op, where he is now left behind with roughly a diopter or so of hypermetropia, meaning that the undercorrection by about 30% worked reasonably well for this child. And with meticulous occlusion therapy, he's been able to achieve 6/12 vision at this point of time at 6 years of age in his life, which is quite good. A word on toric IOLs, and toric IOLs are useful in older children. That is for 2 reasons. One is the keratometry, the basic keratometry tends to stabilize around 6 to 7 years of age, and then the major changes occur only after 40 years of age. And second is, you need children to give good measurements to even consider toric IOLs. So ours is probably the largest study of toric IOLs amongst older children, where we have taken children 7 years up to 15 years of age. And what we did found that the mean post-operative refractive astigmatism drops significantly when you are using toric IOLs, and all patients had a pre-operative astigmatism of minimum 1.5 diopters and more, average being 3.5 diopters. And you can even do a posterior capsulorhexis with an in-the-back toric IOL, which means that the toric IOL stability doesn't change over a period of time. And it's a good tool in reducing amblyopia. And the final case, 8-year-old with insulin diabetes dependent IDDM, and needing a toric IOL significant like we found with our calculation T5. Because he was older, we didn't do much of undercorrection, and is doing well now 3 months post-operatively. We've also done a PCCC, therefore no YAG has been required. Multifocal IOLs have been debated and thought of, but they do tend to reduce the contrast. And I think in a growing eye, our aim is to develop the vision. Children adapt to glasses very, very well. So for us, definitely multifocal IOLs is a no-no. Probably the newer generation extended depth of focus IOLs may have some promising future in older children. We have very limited experience as of now in less than 10 eyes of children more than 13 to 14 years of age who seem to be doing well. So summarizing the talk, accurate biometric assessment is not as easy as in adults. You do need examination under anesthesia in most situations. The basic formulas of SRKT and Holiday-2 work reasonably well. You need to undercorrect based on the age, axial length and the laterality. And the real challenge of pediatric cataract surgery starts after the surgery, along with parents, because it's a long journey to overcome amblyopia. Thank you so much for the patient listening.
Thank you, Shail. And for the last talk, I would like to invite Dr. Twinkle for his talk on toric calculators.
Yeah, Dr. Sai, have you tried about the advanced monofocal like enhanced mode or Clarion type lenses for the pediatric age group?
So we have used the Vivity in now about 8 eyes of children more than 13 years of age. It's too early, or it's too small a number to say too much about it. But I think these kind of lenses where there are no diffractive rings, definitely in older children are something worth considering. Yeah.
Okay, thank you. So we are now towards the end of our instruction course. This is the last talk, and I am going to talk about the toric calculators. What is the posterior corneal astigmatism and how to measure it, and the nomograms regarding it, centered value and IOL tilt factor. This is the recent study which has been published in IGO February 23. That was an evaluation of accuracy of the toric calculators based on the total corneal refractive power. And they had studied about the 3 advanced toric calculators like Abu-Lafayette toric calculator, Barrett toric calculator and Kent toric calculator. But even though they are finding that the 0.6, nearly 6 to or 0.62 dioptric deficit in the toric calculators. So there are still inaccuracies in the toric calculations. So we are going in details how these toric calculators works and which are the still inaccuracies in this toric calculator. So when we go for any toric calculator, it usually have a 2 component. First component is a spherical component, and usually that spherical component we derive from our spherical formulas like our 3rd generation or advanced IOL power calculation formulas. Second component of toric calculator is a keratometry, which gives us which model of the toric implant you have to put and which is the axis of the implantation. So the inaccuracies which we have is the surgical astigmatism calculation. Still we have some not definitive criteria for the calculation of it. Effect of posterior corneal astigmatism, which is variable in the different eyes. Influence of effective lens position on cylindrical power at the corneal plane, that has to be very well understood, and that has to be incorporated in the toric calculators. Few things which is coming up is the optic disc tilt factor, and the new things which is coming up built in the toric calculators is the postoperative IOL tilt factor. So we'll go in detail of each of them. Now SIA, you all of know that the SIA calculator which is available online, Dr. Warren Hill calculator, you have to put your data and you will give your SIA value. But still there is a problem in the SIA that the magnitude is not proper for the validation. Suppose that Dr. Shail is operating the patient and he getting the SIA, the same incision of 2.4 is 0.32, and I am operating the same 2.2, same site, I am getting the 3.8. So the SIA 0.38. So SIA is always a different magnitude in a different wide variations. Orientation is also not a consistent part. Median value is a less sensitive, particularly when there are outliers. So the thing has to be coming up is the centered value. This is most useful for the series of the cases. And now why the centered value has been come up? Because now we have a more advanced optical system, engineering systems, and we have very advanced supercomputers where we can go all theoretical trigonometric calculations. So this advancement gives us an idea about rather than putting in single angle plot of your results, put in a double angle plot and apply trigonometry on this vector analysis. And this vector analysis give you an idea about the centered value. So centered is an average of these vectors that represent the mean SIA value. And the 0.01 is considered as a 2.4 millimeter clear corneal incision. For 2.8, Dr. Douglas Koch is saying that it is 0.12 or 0.13. But if you want to get your own SIA centered value, you can go to ASCRS website. Estimation double angle plot is available over there. You can put your data and you can get your centered value. Second component is the effect of posterior corneal astigmatism. When Dr. Douglas Koch come with this article in 2012 that the standard keratometric and topographic machines are not giving the accurate net corneal astigmatism power. He found out there is a strong correlation between the front cornea and the back cornea. So the posterior corneal astigmatism has always some correlation with the anterior cornea, and also that correlation is also depends upon the with the rule astigmatism or against the rule astigmatism. So they find out that is most of the posterior cornea works as a steep vertical, so it acts as a negative lens. So the posterior cornea acts as a negative lens, so it creates a positive net power plus power in the 180. So it creates against the rule astigmatism. So patient who have a with the rule astigmatism, they will have net effect of the decrease in the WTR, and patient of ATR will have increase in the ATR. So the next year Dr. Baylor come with a nomogram, and this nomogram we were using for the modification of the toric implantation. So suppose we have a patient who have a WTR and a patient has a 3 diopter astigmatism, we were correcting on the toric model. So we were decreasing the toric model at that time. Suppose patient of against the rule astigmatism, we are going for the same model of the toric calculator at that time. So the nomogram has good effectivity, good results as far as the power is concerned. But the meridian was not taken in consideration for that. For the meridian consideration, suppose you apply a nomogram, suppose angular effect. This Barrett toric nomogram, apply a patient who have a WTR of 3 diopter at 70 degree. Actually it should go to 2.3 at the 70 degree. But suppose when we are measuring it, it is 2.3 at the 60 degree. So the meridian power was not taken care. So in 2016, Dr. Ferreira come with this article, and he found out that the posterior astigmatism will change the net power of the corneal astigmatism and axis of the net astigmatism. So nomograms were not taking, addressing the issue. So the algorithms and direct PCM measurements will do. So at that era in the 16-17, we have so many machines has been coming up which can measure the posterior corneal power and astigmatism. So now we have two things, whether you have to estimate the corneal power or you have to calculate. Now this confusion has been cleared up by the certain studies has been conducted by the Dr. Ferreira, and 2018 he come with this study that the comparison between the Barrett, Abulafia, Koch, Panacea and the FICO optics, all these 4 toric calculators were calculated, and they found out there is the lowest astigmatism prediction error. But when they compare it with the estimation and the measuring, no one was the superior one. The same way, there is a certain studies that the different devices which are measuring the posterior corneal power, they have also not equal readings. So this is another study which shows that the significant difference between the total corneal power measurement by the optical biometry and the same way SIMFLUC devices. So there are always so similarities are not there. There is not a university by different machines. So the estimation works very well in the most of the eyes, but outliers have a very worst outcome. And when we consider as a measurement, it works better for the outliers, but there is no gold standard to compare between the total astigmatism power of the cornea by different machines. Now third problem is the influence of effect lens position on cylindrical power at the corneal plane. Now all toric calculators which are coming up, they have calculated either by using the fixed ratio or by using the estimated effective lens position. So what is the ratio? The fixed ratio is assumed as 1.45 to 1 from IOL plane to the corneal plane. But effective lens position has a very high influence on the toricity ratio. So suppose your patient has an average eye, then the toricity ratio is 1.45 to 1. But suppose patient has hyperopic eye, they may shift up to 1.2 to 1. Or suppose patient is a high myopia, it may shift from 1.75 to 1. So the variable toricity ratio is very important. So newer toric calculators are coming up with the variable toricity ratio. So whatever the patient's axial length is there, this thing has been compensated by the newer toric calculators. The same way, not the toricity ratio, but the steep cornea or flat cornea is also affected a lot. If suppose the patient has a very steep cornea or suppose a very flat cornea, the toricity ratio will be changed. So these are the few calculators which are considering the effective lens position toricity ratio. Like Boschen-Lomb and OIA calculators, they do not have a fixed, they have a fixed ratio. So when you are operating the patient of a OIA or Boschen-Lomb, there are high chances to have error when there are extreme of the eyes. So when you go for the implant for the toric implantation with the high myopia or high hyperopia, be careful for this. And the few calculators are also considering the net corneal astigmatism part along with it. So which calculator one should use? A calculator which has a PCA automatically added as a third vector, a variable toricity ratio to be incorporated, calculations, the spherical IOL power using the advanced formula. Like you use the Barrett toric calculator, it will give the spherical power automatically. So those toric calculators works very well. And use a centered value to represent the surgical induced astigmatism. So this is the Alcon online toric calculator which are also incorporating the PCA, posterior corneal astigmatism calculations by measurement or estimation. Both has been considered. This Barrett is also considering the measurement and estimations. Just Dr. Sonu has already elaborated about the Barrett toric calculator. The same way, newer toric calculator like a EVO formula calculator, they are also incorporating the way you can put the measured total corneal power. And CAN formula which has a estimated corneal power. So new toric calculators are coming up and their works very well. And the last and the newer understanding about the optic disc tilt factor on the astigmatism part, certain investigations are going on for that. And another thing is the post-operative tilt factor. Because of the advancement in the topographic tool, we found out that what is the lens anatomy and where the IOL sits into the lens. So quantitative OCTs has been developed for that. And recently, Dr. Douglas Koch and Lee Wang has published a paper on this physiological IOL tilt factor. And they concluded very well that there is a significant mirror symmetry between the right eye and the left eye for the both crystalline lens tilt and the IOL tilt factor. There is a strong correlation in the tilt magnitude in direction between the preoperative lens and the postoperative IOL tilt factor. So in summary, instead of using a SIA value, use a centered value up to 2.4 mm incision 0.1, up to 2.8 mm 0.12. At present scenario, total corneal power estimation and measurement results are equivocal. Use toric calculator which is incorporating centered value, PC estimation, variable toricity ratio, and input the spherical IOL power calculation together. Our upcoming toric calculators are TCP measurement values, and in future calculating tilt factor like Panacea has already incorporated the toric tilt factor calculations. So the incoming toric calculators are coming up which has a calculation of tilt factor. Thanks for your attention. Thank you all the speakers, and we are concluding this session. We invite the next session chair.
No, just 2 minutes more.
Any questions?
Yes. You
Yeah.
Can we have the mic to the audience who wants to ask the questions?
Yeah, you can.
Yeah, I have a question. In the swept source OCT, often we find an optional value, LT, lens thickness is missing. Any insight on why this message comes? Though the question is to Dr. Harshul, but he is not here, so if anybody of you would answer it.
Can you repeat the question, please?
Yes. Sometimes in IL Master 700, an optional value is missing. This is a reading that the machine gives in the printout, and that optional value is lens thickness. Could you provide an insight of why this LT is missing?
I have not used the IOL master, I am using the different machine.
You need to ask the size people in that case, sorry.
Okay, it's fine.
Lady, you had a question. Please
Lady
go to
has
the
a
mic.
question.
Yeah.
Hello everybody. Please, I have a question for our colleague who spoke about IOL calculation in pediatric patients. You said, sir, that you implanted IOL in a neonate 3 months of age, depending on axial length. What about keratometric reading? All we know, keratometric reading calculation is maturation up to 5-7 years. What about keratometric reading?
No, definitely we do measure the keratometry under anesthesia with handheld keratometers. What I was trying to say is that in a certain case, if the eye is so small, or if you do not have access to a handheld keratometer to get an accurate reading, there are standard nomogram charts that as per the age what should be the rough keratometry, you can incorporate that.
Roughly.
Yeah, roughly.
Thank you.
Thank you everybody. So here we conclude our session. We invite the next session chair.